This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. I'm Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. Lee Hyer.
Thank you.
My colleague at the Georgia Neurosurgical Institute. Welcome, Lee. And tonight we're going to discuss one of your new literary productions. Is that right? You've recently published, or in the process of publishing a book. Is that correct?
I am. I've been struggling with this topic for some number of years, and it's sort of the book that everybody wants to do. It's sort of in them. That they believe in, and is a little bit different from others. So maybe we can chat about that tonight. Yeah.
So this is a rather prestigious publisher too. Is this? Am I correct? This is.
It's Springer. Yeah.
Springer Verlag. Did I get that right? Is my German correct? They're a really famous German publisher for medical books and. Really of worldwide repute. Yeah, this is that's quite a thing to do.
Well, then I'm under some press. Huh?
Well, good. Well, good. Let's see. So this is the book. I mean, I don't know. This is the great. I guess you made the comment that many people feel like there's something they want to express, and you've had this desire to write this book for a long time. And dare you tell us the title of the book?
Well, the title has yet to be defined, although the word holistic and aging will be in there someplace. But I've been struggling with working with older folks now going on close to 40 years. And it struck me about 8 years ago that there is really a paradigm shift, that's a trite phrase, that's occurred in the last decade here. And that I've seen phrases in recent publications like there's no such thing as aging.
Yes.
Meaning that it's simply a variable that is impacted by many other variables that are much more important. And when you think about what I do, which is to work with older folks who have physical and mental health problems, that begins to take on a lot of power and importance. And when you look at psychiatry in general, it's rather appalling the amount of progress that's been made over 50 years. In fact,
the answer is not much. Is that what you're saying? And very little, actually.
Very little medication change. The comparative effectiveness of their treatments, including the stuff that I do, the medications, is virtually nil. The efficacy rates for dealing with someone who's older and depressed, let's say, or anxious, or have some cognitive issues or pain, is about 25% with the best of empirically based treatments. And so we have this issue in life with many more people getting older and many more people going to primary care docs, which has now become the psychiatry clinic of choice, where about 80% of meds are dispensed. And people are not getting better, and older folks are having secondary effects because of the medications. Their modal problems of some thinking issues, some depression, some nervousness, and pain issues, as well as adjustment stuff, just get put in this amorphous treatment basket where they do not get targeted for good care.
Well, is some of this just I guess, linguistics as to how a sign-symptom complex is arranged for a particular patient? So if you break your leg, and there's a picture of a broken leg, that's pretty, well, you can easily say what that is. But some strange change in one's affect or mood or ability to make change in later life. I mean, what do you call that? And I think do not people almost demand some kind of treatment for this? So many people are on a variety of medications with relatively little boundaries as to what the sign-symptom complex is.
You said that well, and coincident with that, there's this taxonomy crisis of what really is.
Now you have to say what taxonomy is. There's this there may be a person besides me that doesn't know out there.
That's right. I throw a big word out to confuse people.
Well, I do too, but
there's really a crisis of nomenclature. What do these words mean when you're older? For example, a depressed female who has a baby and then has postpartum depression, and someone who's 80 years of age and depressed, those are different people. And the phenomena of depression is different. And now we know that. We know that depression at late life, anxiety at late life, cognitive stuff at late life, even pain at late life is different. And so the amalgamation of symptoms and what that sort of coalesces to needs to be rethought across the board, and people are really scratching their heads. The DSM-5 is coming out in 2 to 3 years now.
Initials, tell me what that is.
The Diagnostic and Statistical Manual that's used in psychiatry for all of the mental health disorders is coming out in 3 years.
And this is where we get into taxonomy on that. Is that correct? So maybe we could just, that sounds like a nice Greek word, and it's I think it's a classification system, and maybe you could talk a little bit about how important that is, how diseases are classified, what pigeonhole these sign-symptom complexes go in is of enormous importance.
It is. And just to think that if you are depressed and you walk into a primary care doc and you express that you have less interest in things and you're sad and a couple of other markers, chances are you've got other stuff with that.
Yes.
And chances are that expression of your 2 or 3 symptoms or more is different than it would have been 30 years ago. So we have the issue now of the classification being somewhat confusing, and you having not just depression, but probably a little bit of anxiety, maybe a lot of it, probably some cognitive issues because you're older now, and your memory, especially if you're depressed. And we now know that people who are depressed have brain problems that cause difficulty in thinking. And chances are, if you live in, if you're half of the percentage of older folks, you have economic issues, and you have pain and medical issues. The average person who's over 70 takes almost 5 medications, and about 20% take 10 or more medications.
Well, let's discuss that about a few interesting points you've made here. Firstly, I think you've touched on the old mind-brain debate, and if I can just say what that is, it's the idea that mind is some kind of very I guess some spiritual entity. It's complicated, and a lot of, if you can decipher what the mind is doing with interchanges and then from that conversation, you could say the person is depressed or not depressed. Now, I'm a brain guy as a neurosurgeon. The idea is that you're going to see something in the brain. We're going to see sort of a Swiss cheese brain. We'll see some little holes there, or this particular brain will be purple and that one will be red, and we'll be able to say from structural abnormalities what's causing these changes in mood and affect. I mean, I guess that's what I would say. And then the demarcation of, I guess, physiological changes in the brain. There's a lot of work going on, and so there's a whole sort of, I guess, sphere of inquiry going that direction.
Absolutely.
And then there's the sphere of inquiry going into just that's the vineyard you work in many ways, the idea that a particular sign, symptom complex or mood or whatever, that represents a particular disease entity. Is that a fair?
That's fair, and the assumption would be that it's attached to some aspect of the brain. So if you have a brain problem in the frontal lobes, that you can see this with people's behavior. They're not thinking well, there's a connection there. But this information, surprisingly, is not very old.
Yes.
And the correct algorithms for exactly
we have to say what an algorithm is.
Okay, the correct equations for what exactly is going on up here with what is expressed behaviorally have yet to be really defined well. So let's take a classic somebody who comes in with depression. And when I was at Duke 150 years ago, we just dealt with the depression. That's it. And we'd send the person out and they never get better. And often they had other problems. Now when they come in and they have depression for the first time at age 70 or 80, I know that they've got some brain things going on. And so I want to be very sensitive to that. And so the book is intended to really look at the panorama of things. So the typical older person who has a depression at 75, let's say, and is having a little bit of thinking problems, does have brain problems, and typically they're not just the white matter hyperintensities and watershed problems, but they're also things, and the ventricles being bigger and the atrophying of the cortex. But caudate and putamen and other things are also showing clear changes. And if we had a PET scan on them, another scan, we could see other differences.
Right, and this is the penalty for being alive, isn't it? I mean, our bodies, as we, both of us can, I can bear witness to what happens to your body as you age. The same thing is that as your physical habitus is changing, the same thing is occurring in the brain. And for our older relatives, maybe I'm one of them. One has to have a certain sympathy for they repeat the same stories, or maybe they're moody, or they don't snap back as well as they did earlier if the University of Georgia loses some football games. Well, just they're morosely sitting in a chair after a defeat in Athens.
Everybody knows Dr. Robinson at MCCG and Mercer, and they all know that you, as a chronologically gifted professor and distinguished person over there, are as sharp today as you were in other years. And so there are people who beat that, and many people beat that.
Yes.
But let's forward 10 years, 15 years, and let's fantasize that you have a loss of some sort and you get depressed.
Yes, sure.
Chances are you're going to have some brain component to that, and that's now newer information than was, let's say, 5 years ago.
Yes.
And so this book is making an effort to simplify things and not make it too complex by looking at each of these dimensions with depression, anxiety, cognition. We find that cognition is big. If we get people to think better, they get less depressed. And then sort of all the medical sequelae like sleeping and pain. Those tend to be the bigger ones, but there are other ones. And then just the social adjustments. So those are the 5 spokes on the wheel that we really want to sort of target. And then we have chapters on each of those and why they're important and how they interface and case examples.
Just to talk a little bit about the aged brain and the perception of cognitive ability or absence of that. Isn't one of the things that happens is that as you proceed through life, as one goes through life, and you're doing a certain task, or you have a certain life purpose, the more it's a restricted kind of narrow field of inquiry, and your attention is focused on that. And over years, there's a great deal of wisdom that happens in that area. But one of the things that occurs with these older brains, it's very difficult to take on new tasks or do things suddenly try and learn French, shall we say. The aged brain is not going to do as well as if you're an expert in, I don't know, picking winners on football games. You might do very well when you're 70 doing that, but learning French would be difficult. I mean, is that a fair way to say it?
Well, older folks who are especially expert at things learn more and more about less and less.
Yes.
And so what happens is you have the professor at Georgia Tech or Harvard who now is an expert in a specific field of physiology. And there's no one that knows more than that person, but that's a very narrow area. But if that person, I left Princeton 5 years ago, if that person were to be in competition with a Princeton sophomore with a speed of processing task, the Nobel laureates at Princeton would lose hands down every day, all the time. The aged brain cannot deal with speed of processing, complex working memory, and one or two other areas are a little more vague, but those are the big ones where you, just by a function of getting older, start to have penalties. But you compensate for it in other ways. So you get very smart, you get wise, you reflect on things, you take your time.
So just to make this point about, our aged population here, there's a tremendous amount of residual wisdom that's there, along with the the penalties of aging. And I wonder if our society really values their wisdom well enough, just to ask that question. I mean, in a more traditional set of circumstances, if you're a senior person, then you really are responsible for a lot of the a more micro society, I guess, decisions. The Council of Elders would say something, and so that's.
I think you're right, and I think probably this is pure speculation on my part, but my guess is that if you had people in the public realm, I'm talking about powerful people in politics and people who are CEOs, they probably reach asymptote in their 60s to 70s, and then depending on who they are and what they do, they sort of go gently into the night with some sort of organized place where they can.
Not everyone does that.
No, not everyone does that.
Not everyone goes gently. Many people rage against the dark.
And there are a lot of Averil Harrimans who are 91 who are as sharp as they were and very considered. And you have the sense of people like, say, Bill Clinton, who's in his 60s now, it's going to be very wise in his later years. All right, maybe. Maybe
I can swing at that pitch. So I'm not sure what I could say about that, but it certainly is a fruitful point of view.
I'm not talking about its positions, but rather his thinking process.
Many things, yes. Well, you're talking about your book. Back to that, the idea is that you have your view is establishing better diagnostic criteria, and then maybe getting a purer population to try and do something with, and then connect that to observed physiological changes, some PET scans or whatever. Is that?
So what do I have in mind with the assessment and treatment? And basically, it's what I'm seeing in the literature as being simple, as being workable, and as being practical. And those areas to me are that in any of you want a profile of the 5 dimensions that I talked about.
Yes.
So you want to see where the action is, depression or cognition, or maybe just a poor socioeconomic status and problems at home, and you got to deal with that first, those sorts of things. So you have a profile. Once you have that profile, I think the prudent thing that I'm seeing from the literature is that you want to really watch and wait and monitor.
Yes.
I think the problems occur when you jump in right away and give the SSRI for depression or
Now why don't we talk about that? I mean, all these initials. That's
you're
going to do something with serotonin.
Yeah,
I got that.
So you throw a medication at somebody before you really know what are all the problems.
Now I'll say once again for the audience, this serotonin is one of the neurotransmitters in the brain, and so one of the things that goes on in anyone's brain, the aged brain or a younger brain, is these neurotransmitters. They allow the little electrical wires up in your brain to work well. Yeah. And if there are not enough of these transmitters around, the electrical currents in your brain are very slow.
Right.
And so the slow transmission of current can cause all kinds of problems. Yep. And among them can be depression and also cognition issues.
Absolutely.
If those lines are down.
Absolutely. And so again, the idea would be you watch and wait and monitor, and over about a 3 to 4 week period, you then can institute some of the better treatment modules are out there. I don't think it's very helpful. I mean, I have every one of them on my desk. There's maybe 150 studies on depression and anxiety with old folks, and the nuanced differences are kind of silly. And really what matters is getting the person to where they can practically change, having them behaviorally activated, having their environment reasonably friendly, and making sure there's any brain problem that you're addressing. So you deal with the cognition stuff and you deal with the depression stuff that might follow, but you're training them. When we do this at G&I, we have memory clinics and we have computer programs where we help people, and just by doing that, people get less depressed. We now have data on that. We're starting to publish, and you and I have talked about this in the past, and so it's not so much that what I'm saying is radical. It's more this is sort of a culmination of what's out there and just putting it together in sort of hopefully a logical fashion to where other healthcare providers, especially mental health care providers, say, people are going to primary care people for help for cognition, depression, anxiety, pain. Here's a better model to sort of think about, slowing down, targeting in a step care fashion what needs to be done. Having case managers.
One of the issues, and I mean I think we all see this, the number of the medications that people start to take as they grow older, and so it's called polypharmacy. So it's not uncommon in my experience to see a patient that might be on 20 different kinds of medications. So as each of the organ systems become, how should we say it, less agile, different medications are put in to help that organ system. And the problem is there's such a complexity of interactions and effects of all this medication that really is it masks all kinds of things, and particularly with cognitive issues. And maybe I can ask this question. It seems to me, and I've heard of this statistic, there's some kind of enormous number of American population are on psychotropic medications. I mean, some huge, I'm trying to think of the percentage, but 10%, is that a fair number? Maybe more?
That's the exact number. In fact,
good, I got it.
It's doubled between 98 and 2010 to where 10% of our cultured people are on on those medications. And what's even worse is that of that percentage, roughly 2/3 are on 2.
Yes.
And 1/3 are on 3
yes.
psychotropic medications. And when you think of how they compete for the cytochrome 450s and others, this is really, and when you look at better studies on the side effects,
right?
And we could list about 15 of them, and especially with someone who's 75, when you have decreased metabolic capacity, and the kidney is not working as well, and the uptake is not as, we can go through the body, and so this person is really at risk. And not to mention that it's probable that these medications don't need to be taken in this mass amount. Just today, I talked with Dr. Ackerman at Mercer, whom you know well, who is head of geriatrics, and he was telling me about a case that he and I are working with of a PhD psychologist who's in her 70s, who was on about 15 medications, and the first thing he did was take off 5. And 3 of those were psychotropic meds.
Yes. Now, another issue that's out there, particularly in our world, is self-medication. So, I mean, if someone is taking, I'll just say this, cocaine or great amounts of alcohol, I hope coffee is not in this number because I drink a lot of it. But there's a lot of medication that you could say that have impacts, neuronal impacts, and people are doing that. So if you add the issue with these 10% of the American population that are on some kind of psychotropic medication, there's also a huge percentage of people that are on these self-administered. Is that fair? I mean, you throw that in, it's something, isn't it?
The good news is that typically older folks are not on cocaine. They tend to abuse opioids, which are prescription meds, and if they're doing something illegal, it tends to be something that's milder. Although one can't say THC is milder, but something like THC. But that's a very small percentage. The worst drug, of course, is alcohol. So they'll abuse alcohol. Luckily, I've not seen a whole lot of alcohol abusers in the Macon area. I'm from New Jersey, and we had a goodly number there. But it was even cutting down there, because I think typically what happens is the bad alcohol abuser is dead by 60, 65, and so they're not. That's certainly the case in the VA.
Yes. So in looking at the situation, I mean, I think if I could say what your suggestion is going to be, is that a lot of restraint be undertaken in treatment of older people that display these rather classic symptoms of anxiety, depression, and the water is quite muddy because of all of the different medications that are on board here.
Yeah.
And now I'm going to throw some more thoughts out here. Is there any breakthrough coming with just understanding brain physiology, so that is that what's going to give us the answer to the complexities of this brain-mind debate? Are we going to be able to pull something out of the lab that would say what's happening, rather than having some kind of behavioral test or an assessment? Are we going to look at a picture of the brain and say this is like a chest X-ray and here it is? Is that any thoughts about that? We're a long way from that, but any comments?
Well, I don't see this happening in my professional lifetime, and I think I'd shared with you once, maybe here, that I remember sitting in New York City with the dean of Rockefeller University saying in the year 2000, we will have a cure for Alzheimer's disease in 10 years.
Yes.
Well, that not only isn't happening, it's much worse now.
Right.
And I sit on the scientific board of the Alzheimer Federation of America, and there are 9 or 10 scientists of note who are on there, and they're just perplexed. And the issue with the issue of the brain, and especially dementia, is now going upstream. That we don't, when we get a dementing person at age 70, that's the end of the line stuff.
Yes.
We're looking at someone who's now cognitively impaired, the brain is atrophied, and we have other problems. We want to get somebody in their 30s, 40s, and 50s where we have a biomarker that says, Mr. Jones, you are 35 years old and you are at high risk for dementia by 60. Right. That's coming, but it's slow and it's laborious and it's kind of scary, because even if you had that information, we don't have information how to cure it right now.
Right.
So Mr. Smith, who's 35, might not want to know that.
You know, one of the things to remember about the brain, if I can say this, it's the most complicated matter in the universe we know of. It is extremely complicated.
Yeah.
And I think one of the things that needs to be appreciated about it is the extraordinary way these neurons, these little wires in the brain, travel. And some of them are excitatory and some of them are inhibitory. And the balance between that, those wires, some that turn things off and some that turn things on, is so complicated. Yep. And I think there are theories that are at least coming to surface now that maybe some of that may be playing a role in what's up. But having said that, the impact of, I don't know, like a bottle of whiskey every night on this organ is just, I mean, who can say what's going on there with that?
Exactly.
Is that correct?
Yeah, and you enter in noxious substances from the environment, you're really causing trouble. You know, the best model for inhibitory and excitatory neurons is Parkinson's disease.
Yes.
Where the brain is functioning too fast at some moments and too slow at other moments, and the idea is to kind of have a substance that modulates that,
right.
And that's very difficult to do, especially people after 10 to 12 years of having Parkinson's disease. It just becomes very, very difficult. So you know, I think there are so many good centers where good neuroscience is looking, and neuroscience has taken over my field.
Yes.
Where you absolutely know that there's something that's close, but in terms of empirically supported, FDA approved data that says you do this to help this person. Yes. That's a few years down the pike, and so I think you need to be prudent, watch and wait, slow, and then enter in empirically supported treatments that make some sense, even if the perfect algorithms for the care of Mr. Jones, let's say at 75, are not yet known. You want to reasonably approximate what you can do to make that person better.
Yes, yes. Well, now you know, we could turn this into a book advertisement. We could hold the book up and you know, have autographed copies. But you know, when is your book going to reach?
Is another year. We have
another year. Wow. So it's a long. You know, maybe you can tell people how hard it is to do this.
No, it's not easy, and it's not. I'll tell you what's really hard. I've done a couple edited books. The real hard part is sort of doing it yourself and keeping up.
Yes.
Because every time you think you've got the chapter done, you read the journal that comes out the next month, and 2 or 3 new things come in, and so at some point you have to put the period on the sentence.
So this is an extraordinarily difficult thing to say contemporaneous about these things. Well,
it is.
One question is, and I mean, one of the things that I think is revolutionizing medical and scientific inquiry are use of search engines. I mean, have you, in keeping current with things, have you undertaken to do that? You just push a button and you say, give me all the articles on a particular topic?
You know, I used to brag that I could sit at Robert Wood Johnson and get all of the recent journals and at my desk. And now you can do it with an iPad, with an iPhone.
Wow.
And you can get Access Medicine, and you know, you're sitting in the room and you want to find something about diabetes and age and depression and maybe cognition, and you just punch in a few things, and you've got the latest, you know, articles on that.
So, but still, we need a human brain to summate all this. So we still have the human part of the equation. But to me, there's no question the power that we're obtaining in every field of inquiry is more and more than ever. And it's coming, isn't it?
UGA has a new department that I have connection with, empirically supported information, and the issue is how to get good information to the doc in the foxhole.
Yes, right.
And that's a tough one, to get really good information, because there's so much out there, and you know, only maybe 400 people read the key article in the New England Journal of Medicine. You get 400 people, that's it.
Yes.
And so everyone is looking at abstracts, and everyone's looking at cold information, and that's good, because you now know that this is the direction you want to go, but it's also bad because you're not looking at the refinery of what's involved in that article.
Well, you know, it's been a really stimulating discussion tonight, and I hope that you'll keep at it, and we'll talk some more about some of the fascinating inquiries you're undertaking. So thank you so much for coming.
Well, I always appreciate coming here. Thank you.
We'll talk again.
Yeah.
We'll have to get you back again. Thank you. Thanks.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.